I'm still driving, so I'll let you start. Okay. So good
Right.
evening, everyone. We've got a nice crowd. Good to see everyone. Got a few more questions have come in, so I'll let Simon get started. Thanks.
Okay. So we've just got some questions to go through. Let's see. Can the high palate be reduced using a stage 1 appliance? I've seen some cases where the acrylic is removed from the inner area that touches the palate to allow it to be reduced. What's your opinion on this? Yeah, when we use the stage 1 appliance, the expansion creates a nice broad, flat palate. And it seems to work to reshape things very nicely. When I first started many years ago, I used to grind the acrylic on the surface of the fit surface, thinking that if I did so, I could get a better shape to the palette. But I've noticed that I haven't been doing this for at least 10 years, and the shape is still very nice at the end. So I don't think there's any downside to grinding away the acrylic in the most highest vaulted regions, but I haven't done it for a very long time and doesn't seem to have any hindrance to reshaping the palette. I think the important thing to consider is the possible misconception that expansion allows the roof of the palate to drop down. I don't think that happens. The midline suture, the roof of the mouth, is tied to the sphenoid, the vomer of the septum, and that doesn't lengthen to drop the palate. I think what actually happens is the rest of the palate broadens out so that it looks like the palate's dropped, but it's unlikely to have dropped. I think it's just gotten broader across. And our goal isn't to lengthen the face, so that happens through normal growth, but we don't want it to drop because all that does is it increases vertical. And although nature does that naturally, we don't want to excessively encourage this unnatural. But rounding back to the answer to the question is I don't think you actually need to grind any acrylic away. But if you feel like doing so, by all means, it's not going to have any positive or negative effect, in my opinion. Okay, next question. If you believe that the function swallow and speech sets up the posture, then would you say that everyone who has improper oral posture has improper swallow or improper speech pattern in case of a lips or tongue tie? Chicken and the egg question, which comes first, the bad posture or the bad function? If we look back at timelines of when things actually develop, we need to consider when we're talking about correct swallow and correct speech, we need to think, well, at what point in a child's growth and development in their life cycle? Do they develop correct speech and correct adult swallow? The answer is around 2, right? Or roughly somewhere between 14, 15 months to 24 months. So we know that the speech does not begin until the epiglottis and the soft palate separate. And we know that we are still in an infantile swallow while the soft palate and epiglottis are in contact and prior to, the eruption of the D's and the E's. So an infant swallow is appropriate prior to the development of speech, prior to the development of a socked-in molar occlusion. So we know that infants tend to have correct posture because they only have really one posture, because their tongue takes up so much volume. And because they're obligatory nasal breathers, they either hold correct posture or very often they will suffocate because a blocked nose in the infant is life-threatening, because mostly they nasal breathe. They can't nasal breathe, they can't feed, because infants feed and breathe simultaneously. So those who can breathe through the nose can feed simultaneously, so their posture tends to be correct. But if the transition from an infant swallow pattern to a physiologic adult swallow pattern is disrupted by what I suspect is inappropriate early spoon feeding, then very likely that disruption of the timeline, because we tend to spoon feed infants from about 6 months of age, when in fact they're still utilizing an infantile swallow, and spoons require a physiologic adult swallow. If that timeline of using a spoon at roughly 18 months of age, 15, 16, 18 months of age, when the molars sock in, then early use of the spoon creates a suck swallow. So the suck swallow, which is an incorrect swallow, so infants should suckle and toddlers should swallow, but spoons can disrupt that timeline and you end up with a hybrid swallow or a suck swallow at 6 months onwards. So that swallow pattern is incorrect and disrupts the tongue to palate suction effect that is normal in a suckling or a physiologic adult swallow. So it's quite possible that disruption in function is what breaks the rest posture. But equally, if we have a flare-up of nasal congestion or a flare-up of adenoids and tonsils through viruses, bacteria, reflux, all the other normal environmental stimulus that create airway obstructions in infants, then that will also change the natural nasal-only breathing pattern, obligatory nasal breathing pattern, to a survival oral breathing pattern. And of course, if you're mouth breathing, your posture is most likely to be disrupted. So it's a bit long-winded, but that's the reality of posture and functions cohabitation. Next question. How do you handle the additional time it takes to place brackets on anterior teeth to tidy them up? Are we supposed to be able to anticipate the need for brackets ahead of time and add it to our treatment fees up front? Or is it an additional fee we should have in our consent form for every case? In my practice, I know when I do my initial evaluation whether I'm going to need brackets or not. So it's all part of that process. My general fees for the treatment usually already allow for brackets anyway. So I suppose it's my comprehensive level of diagnostic skills over the years has been honed. So I'll know before I start treatment whether I'm going to place brackets or not. So I've factored that in. If you don't have that skill set, then you can make that, if brackets are needed, then there's an additional cost of X amount in your treatment plan. So the main thing is that you either have that fee inclusive within your treatment plan, or you have written down on your treatment plan how you plan to itemize your treatment and make a decision about what the bracketing setup costs will be. Doesn't take me very long to bracket teeth because I've been doing this for a long time. That's also a factor for my practice because it's not a big deal to put 6 brackets on, and it doesn't take that much time. But obviously, if it's not something that you're used to doing it might take you a very long time. So that's just something that you either have to make part of the fee of your of that treatment protocol, or in the written plan you just list the cost of brackets if you have to use them. I'm confused on when we are done with our phase 1 treatment. I would like to tell each patient very clearly up front when we'll be done with treatment. So, depending on the age we start each case, when can we say we should be done? For example, if we start at 5 years of age for crossbite correction, we're done when the 6s are up. If we start a 7-year-old, we're done when all the incisors are in. Would this be a 24-month treatment plan? What about retainers? It would be super helpful if you could specify a basic treatment outline for each age. So phase 1 treatment is this vague, open-ended, when are we done process, right? And for a general rule of thumb, phase 1 treatment is there to create space that wasn't there, with the intention that you're going to tidy up the teeth and do your mechanics in phase 2. So for most orthodontic practices, phase 1 is a set fee, and it's designed specifically as a primary upper only expansion treatment with possible use of 2x4 brackets to tidy up the incisors. So it's designed specifically to correct crossbites and tidy up permanent front incisors. So the timeline for that is very simple. The timeline is when the crossbite is corrected and the palatal cusps of the upper 6-year-old molars touch the buccal cusps of the lower 6-year-old molars, your expansion is complete. And then when the front teeth line up with the brackets, then it's all finished. So you have a clear, defined window of goals. And when those goals are met, your phase 1 treatment is complete. And then you put them in retention and you wait until the final changeover occurs. And then once you're in permanent dentition, you start phase 2, which is the fixed braces. So in ortho, it's a very clear and defined objective. Once you've achieved that objective, you are done. In postural orthodontics, it's very important to understand that it's the same process of management. Right? You define your goals, and you have to make a decision about what your goals are. Right? My goals are different to your goals. My goals are how can I get everything as good as possible without using full fixed braces. Okay, so that's my goal. And as such, my treatment timelines run much longer, but my fees are much higher. You guys don't have the skill sets to be able to get everything sorted out without an orthodontic phase. So you have to make a decision. Well, what is the goal for me for this treatment? Am I just making space and not worrying about the alignment? Am I making space and retraining posture so that I get better skeletal growth and development and not worrying about the permanent alignment? Am I doing space creation, improving the posture, and then tidying up the permanent incisors? Or am I aiming to do a Simon and make space, tidy up the permanent incisors, retrain their posture, and try to avoid fixed braces into the future? So the more goals you have, the longer the time it runs. So what's the timeline? Well, a lot of it depends on what age you start and what those endpoints are. But the earlier you start, the longer your timeline potentially is going to be if your goals are to try to avoid fixed braces in the future. So you've got to make a decision. If you start at 5, well, why are you starting at 5? And you say, well, earlier the better. So, yes, but it also means that you have to be very narrow in focus of your goals, or if your goals are lofty and long reaching, then when you start at 5, you finish at 18, right? Then it's a 13-year treatment plan. Or you might say, well, I'm going to start at 5 because we've got an enormous underbite, right? Huge class 3. So when are you done? Well, when you no longer have a class 3. All right, so that could be one endpoint. You might start at 5 because you have an enormous class 2. When are you done? When you've reduced that class 2 by half, by 3/4, or you have to make a decision. At what point are you finished? Then you've got to make a decision. Are you going to worry about the incisors? All right, the permanent incisors. And if you think, okay, I'm not going to worry about the permanent incisors, I'm just going to stop when I have reduced the class 3 and turned it into class 1. Right? But if you start at 5 and you know that incisors and 6-year molars are going to erupt in 12 months' time, are you going to be able to finish in time? And the answer is you might not be able to have corrected a huge class 3. And then you've got a plan for what? You've got a plan to make sure that the permanent incisors come through okay. And then the answer then is, well, am I just worried about the central incisors, or am I also worried about the lateral incisors? And you said, well, I'm just worried about central incisors. Then central incisors will start the eruption process at 6.5. So by 18 months, you should be done, right? But you say, oh, but what about the laterals? So, okay, well, when do the laterals come out? Well, they come out at 8.5. So now you've got to hang on until 3 years, 3.5 years down the track. So people think, oh, if I start really early, I'm going to get more skeletal changes. Yes, you will. But if you start at the wrong time, then the parents are going to ask you, what about these new front teeth? They're all over the place. What am I going to do about that? And then you've got to make a decision. Is this going to be a 6-month treatment plan? Is this going to be 12-month treatment plan? Is this going to be 18-month treatment plan? So one of the things that you got to decide is how long do you want to treat this patient for? And then you've got to decide, is this a 6-month treatment plan, a 12-month treatment plan, an 18-month treatment plan, a 24-month treatment plan, or a 3-year treatment plan, or a 4-year treatment plan, or whatever length of time? So that's how you set your fee, by saying, how long do you want to treat this patient for? And if you say, okay, I just want to treat them for 6 months. So what are you going to achieve in that 6 months? All right, you figure out what you're going to achieve in that 6 months. You're going to tell parents, this is what I'm going to achieve in the 6 months. So I'm not going to care about the other things that people care about, because I'm just going to treat you for 6 months. Or you might say, I'm going to treat you for 12 months. I'm going to try to make sure that your front, the front teeth line up. Or you might say, I'm going to get the space that I need, correct the posture, and make sure all the permanent incisors line up. All right. Then you've got to think, well, how long is that going to take? Well, it depends on what age they start. Depends on what biological age they start. So not only do you have to figure out what their chronological age is, but you got to figure out what their biological age is. Once you figured out what their biological age is, you got to estimate at what point they're going to erupt the next set of teeth. And then you've got to figure out, well, if things go to plan, this is actually going to take 4 years before all the permanent incisors touch at 10. Okay? And then what happens? Then you got change over the permanent lower canines. So you get another round. So you're going to worry about that. So the time that you take, the goals that you are achieving are based on your diagnostic skills and your understanding of growth and development, the timeline of growth and development. When you understand all this, it's easy. Right? When you don't understand enough, it's confusing. So how do we eliminate the confusion? You need to memorize the eruption sequence and the timelines. You need to be able to recognize what age are they chronological, what age are they biologically. You have to recognize the severity of malocclusion, and you have to make decisions about, are you going to address skeletal issues? Are you going to address dental issues? Are you going to where it's just primary dentition, dental issues? Or are you going to address permanent dentition? Are you going to carry through until they have erupted their 16-year-old molars? Or are you going to stop short of that? Why is it confusing? Because you're not setting goals. Set your goals, know your biology, know where you are now, know what it takes to get you to your goals, and that will tell you your timeline. Once you have that, make decisions about how much you want to charge. Why do I teach you guys to treat at 4 and 5 or at 8, 7 and 8? Right? Because you can set very clear timelines. If you start at 7 and 8, you can finish 9 to 10. If you start at 4 and 5, you can finish at 6. Right? If you want to treat outside of those sweet spots where everything is simple and easy to define, then you're going to end up with plans that run you start at 5, you might not be able to finish until 10. You start at 6, you definitely can't finish until 10. So it's understanding what people's expectations are, what the biological timeline is, what the level of issue you're dealing with, what you're dealing with. Very easy to start anything. The hard thing is to figure out what point you finish, and that just comes with complete understanding. 5, how do you do a model analysis using digital models? I do not have the POS software you refer to in your lectures. So model analysis are done using software. Software that is available through most orthodontic programs. Unfortunately, they're very expensive to purchase, such as Dolphin. Most general dentists are not interested in buying such expansive types of software because it's not their main practice, right? Ortho isn't their main practice. The system that I use is part of a package, right, for the course that I did, right? The $20,000 course that I did, they include the software. The reality is all orthodontic software is very expensive. If you want to spend that money, then you'll have available to you the standard of care orthodontic records that are required or expected of the orthodontic profession. There are services that will do model analysis of the scans that you supply them. Some ortho laboratories will do it. What they effectively do is they take the scans that you send them and they plug it into the very expensive software that they purchase because they get to charge you for it. Just like the Ceph analysis, you can buy services. As far as exploring which ones are available, to be honest, I haven't. That's something that you have to decide. Do you want to do a model analysis? Do you know? Is it something that you're prepared to pay for? Is it the end of the world if you don't do it? I don't know. It will feel like the end of the world if you're in a board hearing and they ask you, where's your model analysis, and you haven't got one. Is it mandatory? I think if you have your Ceph analysis, at least you have your good exam records and you have the treatment plan and your consent forms and you have your photos and you have everything else, then a model analysis is probably the least of your worries. But if you don't have any of the other stuff, then you're not meeting any of the standard of care. So yeah, do an online search, see if there are companies that do model analysis, which there are, absolutely there are. Find out how much it costs and figure out whether you think it's worth paying them to do it or not. Okay, in cases of deep bite, posterior teeth are not erupting into occlusion. Any suggestions for acceleration to allow posterior teeth into occlusion so deep bites can be corrected sooner? So there is a misconception that a deep bite is because of reduced vertical, because the molars aren't erupting. I believe it's a fallacy. I believe the reality is the incisors have over-erupted. The reality is incisors have over-erupted and the posterior teeth are actually where they're roughly supposed to be. So how do we correct this? We actually have to create an open bite. In my practice, I will tip the teeth until I get an open bite and then train the children to rest with their molars together. Right? In every other practice, they'll make a splint, hold the front teeth um, in a position and allow the molars to erupt by having no coverage of the molars. And that can reduce the curve of spade, but it will increase the vertical growth. A 45-year-old heavy-duty bruxer that clenches their teeth might need increased vertical, but anyone under the age of 10, if they have a deep bite, it's because their tongue rests between their molars and their incisors have over-erupted. How do we correct this? We expand sufficiently to allow the tongue to fit between the molars. We create a slight open bite by tipping the incisors, and we teach them the rest with their mouth fully closed and at natural growth, sort out the imbalance from there. That's the postural orthodontic plan. In a complete deep bite case where expansion is required, if we incorporate an anterior bite plane in our palatal expander, what should be the thickness of the plate? By anterior bite plane part, as it will get molars to disclude accordingly. I mean, how apart should the molars be so that the posteriors can erupt, but at the same time, we have to avoid lateral tongue thrust and deep bite, correcting deep bite as well. Usually deep bite is caused by lateral tongue thrust in my understanding. So everything about that I believe is incorrect. I don't believe that a lateral tongue thrust is the majority cause. Occasionally it happens, but resting with the tongue between the molars is the problem. Over eruption of the incisors is a problem, not under eruption of the molars. So I never add in anterior bite planes for deep bite patients. As I said, I think I explained what I do in the treatment for this in the question before. So I don't think our profession has any comprehension of the etiology of deep bite or open bite or any bite. I think everyone just makes stuff up based on observation and treat incorrectly based on incorrect assumptions. So the treatment can be dentally successful, but always unstable. And skeletally is never addressing a primary etiological cause. I've gone through this in the 2-day introduction, advance 1, 2. I would recommend that you revisit the lectures because I'm not sure you understand how posture affects malocclusion and what the driving etiological factors are for malocclusion. And so all these plans are based on incorrect assumptions on the etiology, and unfortunately will be met with very high rates of failure. In a case of Class 2 Division 2, do you recommend 3A palatal expansion, transverse as well as AP direction? So the 3-way appliances I almost never use. They are incredibly bulky in the premaxilla, and I just don't use them. So no, I don't recommend them. I tend to deal with deep bite cases, class 2 division 2 cases by first doing transverse expansion using the stage 1 appliance, and then I will tip the incisors out of the deep bite into a slight open bite with the cat wires. So I still use a stage 1 appliance to treat class 2 division 2. The only time there would be more than one screw is if there was, for example, a loss of E space from an early extraction due to caries or ectopic eruption of the sixes. And then I would be distalizing the six to regain space. But that's purely dental, orthodontic space regaining. And I'll do that first. I might use that as a separate appliance, or I might incorporate that to include a central screw, so that becomes, if you like, a multi-way appliance. But I've never ever used a conventional orthodontic three-way powerful expander. In the lower arch expansion, do you take support on primary second molars or permanent first molars for expansion, as you suggest taking the support of primary second molars in maxilla, then permanent first molars for expansion and mixed dentition? So I will use a second primary molar every time if I can as the anchorage tooth for the appliance. That's my preferred anchor. The only time I would clasp a 6-year-old molar is if the second primary, sorry. The only time I would clasp a first permanent molar is if the second primary molar was missing. And it's irrespective of the arch. My goal is to use the second primary molar. In primary only dentition, I tend to class the first primary molar. In mixed dentition, I will class the second primary molar. And I gave a reasonable amount of refereed literature to support the use of the second primary molar over the first permanent molar. So again, there seems to be confusion about what I do. Please reference the 2-day introduction, because I do spend time going through why I choose the second primary molar. Next question, what effect can rapid expansion cause in the TMJ when done in children until 5, 6 years of age? Could there be any terrible side effects in the future? How can this side effect be prevented? If you look at the refereed literature about orthodontics and the temporomandibular joint, it will categorically state there is nil evidence to show any orthodontic impact on the temporomandibular joint. So that's the official stance of our profession. Nothing we do upsets the joint. Any upset of the joint was going to happen independent of what we do. As far as what I believe upsets the joint, joints are damaged through macro or micro trauma. Macro trauma tends to be physical impact, a knock, a fall, a trauma of some sort. Micro trauma is, as a general rule, bruxing, like clenching and grinding. The predominance of joints that get damaged are in deep bite patients, division 2 malocclusion patients. These are children or adults who rest with their lips together. Their incisors in class 1 relationship in overjet overbite, but their tongue between their molars and often their premolars. This is a slightly open mouth posture. Right? Teeth are apart. And the joint head, the condyle, is slightly off the socket rest position. And what tends to happen is, held long enough, there's additional growth of the condyle trying to reach back to the socket, or the socket trying to grow down to the condyle. This distraction-induced growth creates a situation where the condyle then socks into the socket in that slightly open rest position. And then when these children or adults close into molar contact, the condyle gets jammed tight against the disc and begins to traumatize and damage the disc. So correction of this is to eliminate that retroclination of upper incisors, eliminate the deep bite, create a orthodontic occlusion that discludes the incisors from heavy contact when the molars come together, and then train the children or the adults to rest with their molars together. How does rapid expansion create TMJ issues? From my perspective, I don't do rapid expansion. I do semi-rapid expansion. Rapid expansion is a set of mechanics that is designed specifically to split the midline suture. Splitting the midline suture will cause trauma to the maxilla, but I don't see it specifically causing trauma to the temporal bone or the condyle or the disc. So I'm not sure that rapid maxillary expansion would cause TMJ problems. Okay, last question for today. How do you treat super erupted anteriors in a deep bite by tipping, then intruding them to use TADs? So I just tip them into a slight open bite. I train them to rest with their molars together and the tongue on the palate. And then over time, if the tongue rests against the premaxilla, the stimulus of the tongue tip against the premaxilla will torque the roots forward so that the incisor is upright. So that's how I treat deep bite patients. I don't use TADs. Usually because I'm treating kids under the age of 10, things have not progressed to such a degree of over-eruption. After the age of 10, you can absolutely get into a situation where there is so much malocclusion that it might be wise in a fixed appliance phase to use tabs. Absolutely. Good. All right. Excellent, guys. So that ends our session for today.
Okay, thanks, Simon. Thanks everyone for joining. We just have a quick update. We've got the next. I'll let you go, Simon. I know you got your lunch break. We just have our latest event that's coming up. For those you'd like to join us, or if you've never joined us before, we have an event. I just sent the details in the chat, I believe. Let's double check. Yep. And here's, if you just go to that website, um, straightteethnaturally.com/tickets, you can see all the details. It's in 2 months, roughly, November 7th and 8th. We're going to be doing it on Zoom live stream, so you can join anywhere around the world. The main speaker will be Simon. Kevin Boyd will be joining on day 2. As we have this early bird special, if you join, you get our recordings from last year's event from September 2024, which we held in the Hilton in New Jersey, US. We recorded it. You get that as a bonus, so you can, get started straight away. You could literally watch the 2-day program as soon as you sign up, which had as guest speakers Dr. Matt Wilson and Professor Narinder Singh, ENT. So I have some early bird specials ending next week, next Monday. All the details are here. It's a full 7 hours per day live with plenty of Q&A time, as you can see. Every 2 weeks, we've got Q&A support, just like tonight. That's so you can go through the recordings, ask your questions every couple of weeks. We have a Facebook private forum where you can also ask questions there. We've got some really good specials, 30-40% discounts, $500-$600. We do have some country specials. If you're from different parts of the world, you'd like to apply for additional scholarship specials, just send us an email. All right, so that's it for tonight. You got any questions, just send us an email. Thanks again, everyone. Hope to see you in a couple of weeks. And if you have any questions for me, I'm Dr. Simon Wong's brother and head of enrollment. So just send me an email anytime. Thanks again. Good evening. Good night. And take care. Bye-bye. Thanks, everyone. Thanks, Candace.